Hi, this is Professor Butler, and this is your Pediatric Respiratory Care and Conditions pre-work lecture. This is part of the lesson, and the other half will be discussed in class. So these are kind of your lesson objectives. They're very general, but this is what we're going to talk about. And then we're going to start off by pointing out a couple things here that are specific to the airway when it comes to infants. So infants up to about 6 weeks old are preferred nose breathers, meaning that if there is something that is obstructing their nares, they are not going to automatically open their mouth and start breathing. They will actually decompensate. So it's important to keep their nares clear because they are specifically nose breathers. Their tongue is larger in proportion to their mouth, making the airway obstruction more likely in an unconscious infant. So that means that they have a large tongue compared to when you look at the ratio compared to for an adult. So they can obstruct easy. Their airway is also smallest at the cricoid, which is near the vocal cords. This is a crucial area when we have some possible swelling going on. They are going to actually obstruct, or if they have spasms going on, they're going to get into some respiratory failure pretty quickly in that because of the fact that their airway is relatively small. And this isn't noted on there, but just so that you know that when we're looking at a child, or anybody for that extent, we assess pretty much what their airway size is by looking at their pinky. So if you take a look at your pinky, pretty much that is the size of your upper airway. And so that would also be the size of the ET tube if we needed to put an endotracheal tube down. That's roughly the size that we would use as an estimate on, as far as a tight fit for an ET tube for your airway. All right, so the lung capacity is smaller, so we don't need to use as much volume to expand our lungs. That's a no-brainer. They require higher respiratory rates, and therefore they also have higher demand for oxygen. Another one is, infants and toddlers appear to be barrel-chested. We're going to talk about that term again because when you see somebody who has a barreled chest, so to speak, that is also an indication of possible respiratory failure. Children also heavily rely on diaphragm for breathing, and then they have a lack of firm bony structure, that makes their ribs more pliable, and therefore they can expand more, which also means that they can also do spontaneous pneumothoraxis as well. Now we're going to talk about the structural differences in children. So I'm going to point out a few here. They have a small oral cavity and still a large tongue, increases the risk of obstruction. Their larynx and glottis are higher in the neck, increasing the risk of aspiration. They have large amounts of soft tissue and loosely anchored mucous membranes lining the airway, which increases the risk of edema and obstruction. One here at the top. Lymph tissues, specifically tonsils and adenoids, they grow rapidly in early childhood. So they usually have some issues when they are getting multiple ear infections, eye infections that drain, or sinus infections that drain down. And these particular tissues, adenoids and tonsils, as you probably heard people have their adenoids and tonsils removed, because they usually grow very rapidly. They also can be infected, can have some swelling going on. And when it happens multiple times, that means that we possibly have to get them removed because they can cause obstruction. Now we're going to talk about some differences as far as with the ears, nose, and throat, specifically ears here. So the eustachian tubes are shorter and narrower, and they're more horizontal versus slanted for drainage. Children are more prone to get ear infections, and it can be the result of either virus or bacterial growth in the middle ear. that causes inflammation and also fluid buildup. Some other risk factors involved are if there are any smokers in the home, if they have a high amount of allergies, or they live in an area where they are more prone for severe allergies. And then we talked about before, when caregivers are propping the bottles, that actually can cause them to have increased chances of ear infections. So because of the changes in their eustachian tube, fluid easily gets trapped and it cannot drain well. And so it kind of sits there and it festers, and they can get ear infections repeatedly over and over again. This usually resolves around age 6 to 8 years old. Again, the tonsils and adenoids are part of this lymphatic drainage system. And if they continually become enlarged or they have multiple infections, this can cause obstructions and they need to be removed. Some diagnostic procedures common for children from a respiratory standpoint: chest x-rays, CTs or MRIs, pulmonary function studies like spirometry and peak flow meter. We'll talk about them again later on with asthma. And lung biopsies, bronchoscopes, or basically we call them scoping, blood gases, cultures, all types of cultures, bacterial cultures, viral cultures, nasal swabs, and EtCO2 is end-tidal CO2. So that is a device that we can put on the skin, and it can transduce what is the level of CO2, kind of similar to the pulse ox, where we put pulse ox on fingers and toes and so forth, and that will let us know the percentage of oxygen in the tissues. When doing a pediatric respiratory assessment, it's important to inspect the child's chest, right? And I want to just point out real quickly that we can miss things when we are really up close on a patient, and particularly a child. Sometimes you have to stand back, and you want to definitely inspect by looking. And when I say inspect, you want to see if the chest, one side is higher than the other, right? You want to see the rhythm or the rate of their breathing. Take a look at how they're breathing. Children are always clothed, or even babies are clothed in onesies and so forth. You've got to pull that stuff up. You got to basically expose the chest and take a good look at the respirations and the nature of the respirations, the effort of the respirations before we start listening. We always want to jump on the chest and listen, but sometimes we just need to take a look, because you can miss some really good things. For example, also in an infant, if you're looking at the chest, because their skin is so thin, sometimes we can see some discoloration, which can also let us know that we are having some color change or some cyanosis, or sometimes modeling can be related to respiratory distress as well. So taking a good look at your patient and standing back and look at them. This also includes looking at the depth of respirations, clubbing, skin color, looking at their nares, whether they're flaring their nares, looking at their throat. That obviously requires you to look in their throat, but sometimes you can kind of look and see if they're swallowing a lot, or if they're having difficulty managing their secretions. You can kind of see that either through the drooling or the constant swallowing that you see. Okay, auscultate, you want to listen to all lobes. When you're listening for an infant, it's best to also listen on the side. So what you learn in assessment is ideally a good way and approach to listen, but you also, for infants, you can hear their breath sounds so much better when you listen on the side. Anterior and posterior listening is ideal, but typically what we do is we just listen anterior when it comes to children who are in respiratory distress. Respiratory failure is another whole conversation, but respiratory distress. You also want to see if there's any areas of discomfort. They're not usually sometimes going to be able to clearly tell you unless they're older. So you want to just kind of palpate. You want to ask them to point where it hurts and see if the pain kind of correlates with an inspiration or an expiration. We also want to look at the cap refill. We want to look at their temperature. Is it a high grade temperature or low grade temperature? You want to assess their pulse ox. You want to assess their respiratory rate and heart rate, and their level of consciousness and their work of breathing. And then obviously their breath sounds. This is what we're going to kind of talk about next. So their work of breathing, obviously tachypnea is an increased work of breathing. Please remember the key thing when it comes to infants, that if they're breathing 60 or more, then we do not feed them. And then grunting. So grunting is a sound and an action. And grunting, it sounds like, and really what they're doing is they're kind of force exhaling and maintaining their positive end expiratory pressure, which we'll talk about in class a little bit later. And that is their way of preventing lung collapse. We also have some other sounds and efforts that we typically see. So retractions, or when they are pretty much breathing deeply. And we have different types of retractions. There's intercostal retractions, substernal retractions, and suprasternal retractions. And they go in the order of severity. So suprasternal retractions are very serious. This is when, let me grab my cursor here. So this is when you start seeing the pulling up here. All right, so intercostal is the most common we see for respiratory distress. When we see a patient pulling both your intercostal, your substernal, and your suprasternal, because suprasternal will involve also your intercostal and your substernal, they are working really hard to breathe. Nasal flaring is flaring their nasal passages, because what they're trying to do is expand their airway so they can bring in more air and oxygen. Apnea is a poor sign, obviously. Apnea is declared when somebody stops breathing longer than 20 seconds. So if a child is apneic, so to speak, that means that they have stopped breathing longer than 20 seconds, and it will set off the monitors if they are on a monitor. Now, keep in mind that respiratory rates vary with children, so we don't breathe, and even we don't breathe the same rate every minute, right? Because if I'm talking like right now, my rate is less, and I take a deep breath in when I pause. So with children, however, even when they're lying resting, their breathing respiratory rate is all over the place, which is why it's very important to listen for a whole minute to get a baseline on what that true respiratory rate is. Seesaw breathing is like the epitome of worse retractions, right? So seesaw breathing is a very, should I just say, it's actually, let me just say, it looks like a seesaw. I'm going to show you in class some pictures and some videos so you can kind of connect the visualization to some of these works of breathing. So seesaw breathing is respiratory failure. So if somebody is seesaw breathing, they are in failure and we must breathe for them, meaning we must put them on a ventilator. Head bobbing is also a sign of respiratory distress, possible respiratory failure. And it's because they're breathing so hard that their head appears as it's bobbing up and down, up and down. And I have a video of that as well that I show. So the breath sounds. So the breath sounds are described a little bit different from institution to institution, but bronchi also can be described as coarse breath sounds as well. But these are continuous low in pitch sounds, kind of like snoring. It's like this sound. And it's heard throughout the entire respiratory cycle. So this is you hear this on inspiration and you hear this on expiration. They can clear a little bit with coughing because pretty much, they're just basically moving whatever is blocking the air passages around, but this is also an indication that it's more deep in the lungs, because it's caused by air passing through the larger airways, which would mean the trachea and the large bronchi, and there's usually like pus or fluid involved. Rales are non-continuous versus bronchi are continuous. So rales are non-continuous. They can be meaning they're intermittent. They are usually high pitch, and you hear this popping sound. Okay. Also, these are also called crackles. All right, this means you got a lot of fluid going on, and this usually isn't clear by coughing because we're going to continue to hear that popping sound. Some people describe it as hair rolling between your fingers. All right, this is air passing through smaller airways. So this is the infection or whatever is going on has reached the alveoli or the bronchioles. This is commonly heard in pneumonia. All right. Coarse crackles is that low-pitched bubbling sound. This again is indicating that there's fluid in the bronchioles or the bronchi. So it's kind of a combination of the two I just talked about. Big one here that you definitely will hear a lot about in this lesson is stridor. And this is a harsh, high-pitched sound. This means that there's something going on in the upper airway. It can also be described as barky or crowing sound upon inspiration, and is typically associated with our croup syndromes that we'll talk more about in class. Wheezing, we are all pretty much familiar with. We associate that with asthma. It's usually upon expiration, but it can be both inspiration and expiration. It is a high-pitched musical hissing sound caused by airway narrowing or a foreign body actually entering into the airway. And that foreign body doesn't necessarily mean like a toy or so forth, which it could be that. It also could mean that the child has some type of tumor or mass in their airway. Let's see here. And then we have diminished breath sounds. So that just means just that, your breath sounds are diminished. That means that you listen to one side versus the other side, and you can barely hear one side versus the other. And then absent means you don't hear anything on that side at all, which is an emergency. Some of the techniques we do to actually clear the airway, also we call this pulmonary toileting, as you see here on the slide. We can do postural drainage. So postural means we are going to put them in a position, and that is going to help facilitate drainage in either from the upper airway or the lower airway. So it depends on how they're positioned. But basically, we are positioning them in a fashion that will help facilitate drainage. Vest therapy. So this little boy here in the picture has the vest on. They actually do enjoy the vest therapy, and it really basically is shaking them up. It just kind of vibrates them. And so when it vibrates them, it's basically shaking up some of the secretions, kind of moving things around so that hopefully he can cough it up and help clear his airway of any mucus or any drainage. IVP. So IVP is not, there's not a picture on here. IVP is a treatment that we give at the same time that we're using some type of medical device. And it's, I probably have a picture. I'll see if I can find a video of it. They don't like it. They don't like it at all because it's giving pressurized air while they're getting their aerosol treatments, like a bronchodilator or so forth. And what it's doing is it's using that pressure to help open up the airways, especially the lower airways, and getting the medication there and also loosening secretions at the same time. So I look at their face and they feel uncomfortable just simply because of the pressure that's being applied while giving the treatment. So chest PT. So chest PT is simply that. It's the cupping of the hand or using a device. So you can either use a vibrator or you can cup their hand. And you're basically going over all of the chest from a posterior and anterior area. And that is kind of just shaking things up and moving things and help facilitate the removal of any type of drainage. Cough assist. This is the picture at the bottom. So cough assist. And this is the cough assist machine, and the child is hooked up to a pulse ox, and this is a heater back here. So what they're doing is they're basically applying pressure. This machine has a setting where we actually set the pressures. So what they'll do is they'll push air and then suck it right back out. So the machine is not breathing for the child. It's basically using this pressurized air both in and out to kind of elicit a cough. That's why it's called cough assist. And hopefully that will help them and help the diaphragm, give a little boost with the diaphragm to get the child to actually do a good cough so that we can either suction whatever is in there out, or they can cough it out themselves. They don't like that one either because it is uncomfortable, because we are, again, using pressurized air, and that doesn't feel too great. All right, so now we're going to talk about trachs. So trachs are very common in pediatrics. Trachs are always viewed as a way of support, and the goal is always for a child to not live with a trach. So the goal is always for them to have their trach, what we call decannulation, as you see there on the list of things, for them to become decannulated. Children get trachs for structural malformations that they're born with, and they just need some time for their airway to grow in order for them to be able to breathe on their own. There could be trauma related. Let's see, what's some other ones? Oh, and there could be a syndrome. So there's nothing wrong with their airway, but there's something wrong with their lungs, so to speak. So their ability to breathe for themselves is impaired. Therefore, we have to have a long-term trach in place in order to facilitate ventilation. So this, there always are some things you really got to be careful about with trachs, and it is required for you to watch the CHOA trach video. It is a great video where they show you basically trach care and trach changing. I'm going to go over some things you always need to remember, but the video will go over things a little bit more. So trach care means that we are going to change the ties. So as you see that there's ties here, you probably know this from, I believe, actually no, you go over trach stuff later on. So there are ties. There's some type of a cloth. Sometimes they use chains, excuse me. Sometimes they used to use shoestrings in the past. Actually, when trachs are delivered to the patient, they actually have some type of string that is with the actual packaging. But we like to use the Velcro straps. As you can see, hers are blue. They come in all pretty colors that can match their outfits and so forth. Anyhow, so these are changed twice a day, or when they get really wet. And then they let them dry. We wash them and let them dry and change them out as necessary with the next trach change. Trach changes is when we are actually going to take the trach out and put in another trach. And this is a routine practice. Rarely will you see intercannula trachs where you have a inner cannula in place and all you're doing is changing out the disposable inner cannula. All right. So we actually take the complete device out of the stoma and we put in a totally new or sterilized trach. Again, the goal is for them to be decannulated. And the reason why we don't have something in place is because if we do, the tissues are going to form around that trach. And it's going to be a permanent trach because we then cannot take something out that tissue has basically formed itself around that is traumatic and they will die. So, because that's the only other way we can breathe for them. And so what we do is we do trach changes every week. And so when you're taking care of a child with a trach, it's important to know which day of the week that they have their trach changes. So we always would say, hey, when's their trach changes? It's every Wednesday and it's Monday. We know we need to put that on the plan of care, that we need to do trach changes every Wednesday or the child is due for a trach change. Again, we would change out the whole thing. All trach care and trach changes are done with two professionals. It could be a respiratory therapist and a respiratory therapist. It could be a nurse and a nurse. It could be a nurse and a respiratory therapist. It could be a trained parent and either one of those two. Either way, whoever is doing the care, two people should do it. And those two individuals have to be trained to do it. So we can use a parent. The tightness around for the Velcro is always checked and made sure that it is not looser than 2 fingers that can get in between the tie and their neck. If I can get 3 fingers through there, that is too loose, and that trach can actually fall out, because as you just heard, we do trach changes every week. So it is not sutured. It is not permanently in there. It is very easy to get that trach popped out. And kids sometimes will do that because they think it's funny, and hand us their trach and be turning blue at the same time. And like, seriously, if you just want my attention, all you have to do is just say something. And we now have to just grab the emergency trachs, which we're going to talk about in a second, the emergency trachs, and get them and put one of them in. And then put them in timeout. Okay, so emergency trachs have to be there with the child. Each trach has a specific size because, as you learned, that they all have different sizes of airways as they grow. And so whatever size they are at 1 is probably not going to be the same size they have at 3, right? So we sometimes have to upsize them because we can have air leaking through. Either way, you have to have emergency trachs. You have to have the same size trach, and you have to have one size smaller. So if this child looks like she's probably a 3.5, looks like she's got a Shiley-in. So let's just say she has a 3.5 Shiley trach-in. I would make sure that I have a 3.5 with me in her emergency bag, as well as a 3.0. Because if for some reason that trach comes out and some time lapse between me actually being able to get the 3.5 in, her airway automatically is going to start to close. As soon as that trach comes out, that stoma wants to close. So you're going to see swelling. And if it was a traumatic decannulation, accidental decannulation, if it was an accidental or and there was some trauma to it, there could be some bleeding going on. So we need a smaller size to possibly get through a smaller passageway or smaller stoma because of swelling. These children are also higher risk for infections. Nobody can be smoking around them. They always should have, I like this picture because she's cute, but she also has something she doesn't have something on that's required. And I'm circling my cursor here. So if you're looking at it, this is the trach is open to air. Trachs bypass our normal filtration system, which is our nares and everything up here in our upper airway. So we have, I can't remember the little hairs in our noses, and then our upper airway is nice and warm. So by the time the airway hits our lungs, it's filtrated and it's warmed. That doesn't happen with somebody with a trach. It goes directly in past their vocal cords directly to the lungs. So we have to put what we call some type of humidification and filtration device on the top of the trach at all times, so that we don't have anything getting into the lungs that's not filtrated and heated and warmed. And so we have Pasteur valves, we have HMEs, we have all these little things that we're supposed to. So she's supposed to have HME on her trach while she's outside, but she doesn't. So anyway. So some other safety measures besides making sure that there's some humidification and filtration on the child is that we have to watch them in water because they can easily get water into their trach. So they have to be very careful in pools. We do have devices that they can use so that they can swim, not underwater, but they can get into a pool so they can't be submerged. The same thing goes for bathtubs, because they probably have soap and bubble baths and stuff like that, but we just have to be very careful. They can't have little beads and stuff like that to play with because they can easily put them down their trach. And then the beaches are a big caution because of all the sand that's around. So parents have to be very careful about playing in the sandbox and being at the beach because sand can very easily get into the trach, and that will be very irritating to the lungs. All right. So next we're going to talk about otitis media. This is basically aka ear infections. Children usually present with the following symptoms when they do have an ear infection. They'll be pulling at their ears because they feel that fullness, that pressure. They might have fever, especially if it's a bacterial infection. They'll be very fussy because as they eat, and they're starting to suck and swallow, that pressure actually gets worse every single time they swallow. So they'll be having a lot of pain and discomfort, and sometimes children won't eat and they can become dehydrated. Treatment usually is antibiotics. Some of the complications for ear infections that are not managed well, they can actually have hearing loss. The eardrum can be perforated, and they can end up, again, if they have hearing loss, the development of language is going to possibly be impaired, and they could have speech problems. So there are 3 types of ear infections I want you to kind of know. First, let me show you what a normal eardrum looks like. So when we inspect in the ear, we should see this nice pearly looking eardrum. So this is a perfectly looking eardrum. As they develop otitis media or acute otitis media, you'll see red, you'll see maybe some pressure, some bulging of the eardrum. And then when we get to OME, which is the highest type, when we have some type of effusion, you'll see this, I think it's called, let me just make sure I'm saying this right. This is calcification. I know I was going to say that wrong. So this is calcification of the eardrum. This eardrum has ruptured and actually, so you see some calcification, or this starts to become really hard in the eardrum area. So this is definitely not something we want to see. All right, so let's see here. I have this picture of tubes, because treatment is basically appropriate antibiotics, obviously rest, making sure they stay hydrated. And at some point, if they continually have problems, then they're going to have to put in what we call, it's basically a drain, but they're ear tubes. So this is an ear tube. They got all different type of ear tubes. This is a common one. It just depends on the surgeon. This is another type. And they eventually will fall out. We tell them, nursing needs to teach them about the fact that it will fall out so they don't freak out, and that they have to wear earplugs when they're taking a shower or bathing or swimming, especially in lakes and oceans, because that is usually has bacteria in it. So parents need to be alerted for that. And this is just pictures again of what it looks like when you're visualizing in the ear and somebody has a ear tube. This is what it looks like. All right, so let's keep going and let's talk about foreign body aspiration. So children put things in their mouths all the time, especially our infants, and sometimes things are aspirated and it can cause a host of problems. This picture here shows you it got past the vocal cords and it's going into, looks like the right main stem bronchus. This goes to the left, let's just say, and I have no idea what that foreign body is. Looks like a toy or something. That's why it's very important to be careful about the size of the foods, because it could be food. It actually could be liquids as well. So don't forget that foreign body aspiration is anything foreign that's not supposed to be there. So that could be stomach acids. So somebody who has severe reflux that's aspirating all the way to the top could actually be aspirating down in their lungs, and that's a pH of 2. That's not good. It could be a actual toy. It could be food, anything that's not supposed to be in the airway. What we typically hear from a parent is that they have onset sudden episode of coughing without any history of having any respiratory infection. Okay, so this is somebody who all of a sudden abruptly is having this coughing spell. This isn't an occlusion, so to speak. This is an aspiration, but it could occlude eventually. Because this child, for example, in this picture could get air this way, and so we probably hear diminished breath sounds on the right side, but not the left side. And they're constantly coughing. Respiratory assessment and history is very, very important. So we hear something like this and we see that the child is not in a respiratory failure situation. They're just coughing, coughing, coughing. They seem very uncomfortable. The first thing you need to ask is, what was the child doing right before this happened? That's exactly what was the child doing right before this happened? They were playing with their Legos. Okay. What size were the Legos? Were they the big Legos or were they the little Legos? Right? Or they were helping their sister or brother with a activity, putting together a car that has small pieces, right? Stuff like that. Or the father that came into urgent care, said he literally just walked away for 1 second to get something from the kitchen, and he was just changing the batteries of something. Child came back. The child was coughing. He looked weird, acting weird. He looked down. He saw the batteries. He's like, I'm missing one. He picked up the child and ran to the urgent care. He was a doctor. He was like, oh no. So it can literally happen very quickly. So the severity and the symptoms depend on the item and the location. And the next slide really shows you kind of some of the clinical findings. Now, I don't want you to necessarily, worry about that. I want you to focus on what are the signs. What does a nurse need to do when she suspects or he suspects foreign body aspiration? And then ideally, what is the next best step? So again, you need to assess. It depends on the item. You need to find out what was that child doing. We have to sometimes get good x-rays basically from the head all the way to the anus, because we want to make sure where the object is located. And we need to make sure it's moving along the normal trajectory and the child's not having distress. Because sometimes we don't really do anything depending on what it is, and we will just watch and make sure that the child poops it out, right? But then there are some things that we probably need to do a little bit of intervention. So again, it depends on the item. Monitoring the child is very important, especially after the item is removed. Some complications that can occur, obviously, is pneumonia. So they can actually develop a massive infection. They can go into respiratory failure, and some people could actually die from this. So this is a video. It talks about normal breathing video. I actually like this video. It's very brief. It gives good animation here of the diaphragm and the lungs, because we're about to go into what I think really needs to be reviewed is how do we breathe? And what are some of the things you really need to understand before you come to class? Because when we come to class, we're going to jump into the conditions, but we're also going to do an activity that, one, you need to identify or just kind of have an understanding the difference between volume and pressure. You also need to understand how to read a respiratory order. Just how you understand how to read a medication order, you need to understand what your patient is on. Especially in pediatrics, we emphasize this a lot because respiratory and dehydration are the two top conditions that we deal with in pediatrics. So there's a lot of emphasis put onto this. So please make sure you watch this. Also, this one is the best one. So this is Khan Academy, and this really goes over a lot of what you'll see. And it talks about the increase in pressure, the decrease in pressure, and this is actually going to be on your test. So you need to make sure you watch these videos and have an understanding of when we breathe in. I am going to start class and I'm going to go through what I show with my 60 cc syringe, because this is a great illustration of pressure and making sure that everybody understands that concept. And then we'll go ahead into a little activity before we jump into our conditions. So what I also want you to understand is that we have different parts of respiratory orders. So I'm going to explain this now, and in a video they're going to explain to you a little bit more, and then we will elaborate in class. So a device is either like a nasal cannula, BiPAP, CPAP, ventilator, and so forth. So the order will always start with what kind of device is this child on. They're on a nasal cannula. They're on high flow. They're on a vent. We are on a ventilator. If it's on a ventilator, they're going to talk to you about the mode. So SIMV means synchronized, mechanical, intermittent ventilation. That's what it stands for. or they're on a volume support or so forth. You do not need to memorize that, but just I'm letting you know that if they are on a ventilator, you would need to know what the mode is. There are two different types of ventilation support that we provide. We're either giving pressure support or we are either giving volume support. And you need to know that each one of the devices that we'll talk about in class are either giving pressure or they're giving volume. There are some that can do both. They're more so on the more advanced side. FiO2, so what amount of oxygen they're on. Oxygen is titrated from 21% to 100%. What we're breathing right now is 21%, which is considered room air. But we can titrate our devices, especially in pediatrics, up to 100%. Is there a rate? Right? So that means, is the device that you're using giving any type of rate or supporting the breaths per minute? So if they are on a specific device that can do that, you would want to know what is the rate. If they are on a device where they're not necessarily getting a rate, but a device may have what we call a backup rate, if they stop breathing for more than 20 seconds, that tells the machine like it has not sensed that they've taken a breath greater than 20 seconds. These machines and devices will automatically start breathing for them. So that backup rate of 18, so to speak, if it senses that they have not taken a breath for more than 20 seconds, it will start breathing for them at a backup rate of 18 breaths per minute. If they are on a device that provides volume or just some type of flow, 2 liters, 3 liters, 4 liters, 5 liters, 6 liters, that is what you also will hear and report as well. So what is the flow? What is the amount of flow? So nasal cannula is a perfect example of the flow. The patient is on a nasal cannula of 40% at 4 liters. All right. And then where should we be maintaining their saturations? So we know what the normal maintaining level is, right? But that can be actually altered for certain patients where we might need to accept saturations that are less. So in our cardiac lecture, we'll talk about that a lot. So our saturations could be, the doctor says to maintain saturations between 85 and 92. All right. So I gave you some examples of some orders down there at the bottom. So 4 liters nasal cannula at 35%. This patient is on CPAP 7 at 50%. 7 millimeters Hg. I put that there so you understand that that's a pressure, but when we write it, we usually just write CMs. Ventilator of SIMV 21/7 with FiO2 at 40%. These are the things that nurses need to know. Now, respiratory therapists, they need to know a whole lot more usually, but for our purposes in being able to care for the patient, we just need to know these basic things depending on the respiratory support that they are on. All right, so I think what I'm going to do, actually, I'm gonna do this one more slide. So respiratory distress versus respiratory failure. So respiratory distress, usually these are the things, and I'm gonna go through them. These are the things where we wanna catch our patients in and make sure that they do not go into respiratory failure. So distress could be the patient is tachypnic, they're very irritable because they're air hungry, right? Or they're oxygen hungry. Their heart rate will be elevated because the body's not getting enough oxygen. They'll be retracting, maybe those substernal, maybe intercostal. They'll be doing some of that nasal flaring. You might actually hear some wheezing or coarse breath sounds, or even the stridor that I mentioned before if the problem is in the upper airway. Their increased work of breathing, they could be grunting, for example. Small increments, so they'll have small increments in oxygen, or they'll have increased oxygen demand, meaning our oxygen being delivered to them is at like at 50% or more. Their blood gas actually, and well, probably small increments. Sorry, their oxygen probably will not be that big. So maybe they're on 30%, 25%. Sorry, I said that wrong. Blood gas is normal. So if we were to do a blood gas, we might see some issues with it, but pretty much it's normal because they're compensating. Their bodies has enough reserve to compensate for what's going on physiologically. And their saturations are usually 90% or greater, again, on minimum support, respiratory support, because they're able to maintain. So that is where we want to catch people, because we don't want them to jump into respiratory failure. And children in particular jump from respiratory distress to respiratory failure very quick, because I stated before, they have decreased lung capacity. They have less reserves. They do not have the reserves that me and you have as adults to be able to be in a respiratory distress situation longer before help arrives. So we have to usually act very fast, and I mean very fast, especially the younger they are, the less reserves that they have to prevent them from going into failure. So failure would be they're apneic, they're not breathing, right? That's not good. Tachycardia usually means their heart rate is above 180. Or worse, they've actually worked so hard that now they're becoming bradycardic now. That's a very ominous sign. Lethargic or unresponsive, that means their level of consciousness is decreased. Suprasternal retractions that I talked about before, we can't get their sats above 90%, and they're even on a high level support as well as oxygen. The high respiratory support device that they're on is really high, like a ventilator, and we'll talk about different devices later on. We're seeing color change. We're seeing mottledness. They're mottled. They're cyanotic. And then their blood gas is abnormal. So this is not what we want to see. All right, so this concludes this pre-work. I will upload your quiz. It'll be available a week beforehand. If you have any questions, please let me know.